Okay, hello and welcome. Thank you everyone for finding us. Today I'm having a conversation with Marcus Evans. So welcome, Marcus. I'll let you introduce yourself and just tell people who don't know who you are a little bit about who you are and how you've come to be talking to me.
Well, I'm a psychoanalyst, worked in the health service for 40 years and resigned from the Tavistock. I mean, that's not what I was known for, actually. I was known for my interest is in applying psychoanalytic thinking to psychiatric settings. So the thing I get asked to talk about is psychoanalytic understanding of psychosis and personality disorder before resigning from the Tavistock over the gender issue.
Yeah. So I guess we were just saying before we hit record, there'll be people in this audience who may not have heard very much about what's going on. There'll be others who've been following this for years. But just let people know or explain what the Tavistock is, because a lot of people will refer to that. But just let people know what we mean when we talk about the Tavistock.
So the Tavistock is the national, it's an NHS organisation. It's the smallest trust in the country. And if you thought of it as a specialist organisation, it's really set up to provide psychotherapy trainings. It's mainly individual psychotherapy, group psychotherapy, and family system psychotherapy. The other division is that there's a child and family department. So they do a lot of child psychotherapy trainings. And then there's an adolescent and adult department. And there's a place called the Portman Clinic, which is for the treatment of people with sort of forensic disorders, if you like.
Yeah. And so your role there was as a governor?
No, I was actually a senior member of staff. So I used to do the lecturing and teaching, but I was a psychiatric nurse, and they headhunted me because they wanted the Tavistock to do more, offer more to nurses. And so I was the first nurse that was appointed there. So I was what was grandly called head of nursing. I mean, you don't have any beds. It's literally psychotherapy rooms and then teaching. And I used to do outreach teaching. So I would organise for myself or other members of staff to go out to mental health trusts and provide teaching there. And then latterly, I was in charge. I was the person in charge of the adolescent and adult department. So I used to sort of run those departments for about 5 years. But I retired from the NHS in 2018, and then I took up a voluntary position as the governor, one of the governors, sorry, not the governor, but on the board of governors. And it's basically a voluntary board that oversees that the trust is doing what it's supposed to be doing.
Yeah. I suppose while we're looking at definitions, you talked about psychoanalyst. Do you want to explain a little bit about what what that looks like in practice in terms of the sort of session, what sort of issues people would come to those sorts of clinicians with?
Yeah, I mean, so basically it's trying to understand the sort of unconscious mind. So if you think of cognitive behavioral therapy, you know, is thinking about the things we're conscious of, whereas psychoanalysis looks at the things that sort of drive us as people, sort of patterns of behavior and unconscious patterns of relating and thinking about the world. And so you're sort of trying to throw a light on unconscious preoccupations.
Yeah.
Yeah. And then helping people in that way. And in terms of who we'd seen, well, you know, most people that sort of come into psychotherapy it's a whole range. But, you know, in a way, you'd say that people who are depressed or anxious or phobic or suffer from obsessive compulsive disorders. And then my particular interest was applying that way of thinking to people who've got more serious sort of characterological difficulties, let's put it like that.
Yeah. So then in terms of kind of gender identity issues that those of us who've been following this, are aware of with the Tavistock. What was your kind of perception of them or understanding of that in terms of the provision, or what the landscape was like with the Tavistock kind of before your involvement, and kind of what changed?
A little bit of a history of this. So 40 years, a long time to be in psychiatry, and for the first 25 years, I worked at the Maudsley, and I used to run a parasuicide service in a day hospital, all sorts of things. But you'd say that the presentation, in terms of, I'm not answering your question about gender dysphoria, I'm talking about the presentation of people who would transition. Mm-hmm. You're talking about very small numbers of mainly males to females, mm-hmm. post 18. Mm-hmm. Now, even in those days, sort of pounds, shillings and pence, there are all sorts of false claims, false science bandied about in this area. There's a real absence of hard clinical data, mainly because recently the politicization has made it such a difficult topic to behave in an ordinary clinical way. People are frightened of undergoing research. They get accused of transphobia and things get shut down, and you're not allowed to debate things. So there's if you just take it, there's an absence of the sort of data that clinically you would need in order to look after patients and think seriously about what will help them and what might harm them. Yeah. So, okay, going back to, let's say I ran a parasuicide service at King's, people taking overdose and presenting to King's College Hospital. It's the biggest casualty in the country. And even in those days, we're talking about the late 80s, early 90s, it was generally believed that all but 1% of people who transition made a successful transition. Mm-hmm. Now, my anecdotal experience of that was that can't be accurate, because we had a fair few number of people who would present to King's Casualty having taken an overdose, and the story would be they got complex problems. They believed that transition would cure their problems. They would then transition, and then they've got the same problems, and they'd be extremely disappointed and suicidal. So I used to see a proportion of those patients. Now, it's not to say that some of that old population didn't make successful transitions. They did. It's just that there's always been, in my experience, a tendency to sort of overplay the argument, and an absence of serious long-term research and data. Okay, so those were in the that was a long time ago. Then my wife took up a post at the Gender Identity Development Service in 2004, 2005, and then it was small numbers of mainly males to females. The age range had come down because there's ongoing pressure to give medications earlier and earlier and earlier. So she used to come back and say she was alarmed that an institution which was known for its sort of interrogation of psychological factors, whether in the family or in the individual, was sort of fast tracking people through. So she'd see or hear of cases where somebody would present with gender dysphoria, and then after 4 sessions, in which it seemed like a rather superficial investigation, they were off to the endocrinology department. So there was a sort of idea that this place is operating very differently to the rest of the trust. Now, then she got so worried about it, she tried to discuss it with the team. She felt that her questions and her worries were not welcome. Again, very different, because it's a sort of multidisciplinary approach at Tavistock. We're used to thrashing over ideas and looking at the downside of treatment and could it be this or could it be that? But there's a sense that this was not welcome. So she tried to discuss it with the team. Eventually, after about 6 months of struggling away on her own with this, I think there were other people who were skeptical but would keep their views to themselves. She went to the medical director of that time, who was David Taylor. He did an investigation and he basically said there's not enough sound medical thought about this. We don't know what's going to happen to these kids. We're not following them up. The usual sort of clinical governance is the thing whereby any medical service you go to, there's a sort of clinical governance which you may or may not know about, but it sort of checks and balances to see that medicine is acting appropriately in terms of thinking about the downside of treatment and the outcomes, etc., etc. Anyway, that was all missing. Sue then, nothing changed. He then moved on. He was a medical director for a period of time, and in a way, all got forgotten about. That was in 2006, and there was a Newsnight program about it. They managed to find his original report. So roll forward to 2019, and probably the best known clinician in the Tavistock, David Bell, had been a governor. He was approached by the staff from the same service, basically saying the same things that Sue said in 2005, which were these kids have got comorbid problems, they're on the autistic spectrum, they've got family dynamic issues going on, there's insufficient investigation into what is troubling them, and they're being pushed on to puberty blockers. And now it's important to note that by now the numbers are hugely expanded, absolutely through the roof. The other thing is the cohort's very different. This is now something like 80% female to male and a much younger age group. So a completely different cohort than the old cohort that I was used to 15 years ago. And you think that the Tavistock would be curious about what on earth is going on, you know, and but now again, my experience was David Bell wrote a report which was challenging, but it is helpful because it's a treatment that's going to have a long-term implications for these kids, and yet we really don't know what the outcomes are going to be, and we don't know what the research is or how these kids are going to do later on in life. But the other thing that was amazing to me was no one seemed very interested. In fact, I asked the medical director at the time, what about the follow-ups? Now, every part of the trust has to do follow-ups because the way we win contracts from NHS providers is by producing information that says such and such came in, they had this problem, they had psychotherapy, and then they said it helped, it didn't help, whatever. These are our outcomes. So you follow up and then you report back to the commissioners. These are the results of our investment. No follow-up. The most controversial service in the trust with kids, we're not following them up. What is going on? So sorry to go on a bit, but anyway, I and one or two others started to argue with the trust about the way they were approaching this issue and their lack of willingness to investigate the problem that they were being presented with. And I felt we were just, no one was interested. There's obviously a sort of, the political tail was wagging the clinical dog. And I'd signed a confidentiality agreement, which meant I couldn't talk to anybody about it. So I resigned and was then approached by lots of people from the press who wanted to know what had gone on.
Yeah. So you talk about the kind of the political tail wagging the dog, clinical dog, and the pressure for kind of putting kids on puberty blocker and for it being younger and younger, what was your sense of, and how soon did you kind of see or realize where that was, what was driving that?
Well, one of the things,
where was that coming from, and who was that coming from?
Yeah, I mean, look, the patients often they're psychically, you know, they're wanting to shut things down. They're often, I mean, so Dominica Gicelli, who set the service up, he thought puberty blockers were like a pause for thought for kids who are not ready for the challenge of puberty and adult sexuality that gets sort of thrown into the child's world. Now, the thing, just to go to the judgment, just going to the end, well, part of the way, sort of, the judgment is actually, once you put people on the medical pathway, they it's not a pause for thought. They have a bit of thought and then they get off. They keep going. You're on a medical conveyor belt.
Yeah.
90% of them go on to cross-sex hormones. So what happens is, but the basic idea, if you said that our experience is, you know, that these are people with complicated problems. They feel threatened by the challenge of puberty and adulthood down the line, and they want to just shut the system down. And you know, yeah, and really what they need is psychological understanding. That would be my point of view. And I don't know why the Tavistock didn't stick to what it's actually good at and known for. Yeah. In trying to help the kids understand what is going on for them and why they can't cope. The problem is, sorry, going back to your question, is they're often very fixed. They think they found a solution. There's the keys to their solution. And if you oppose them, you are, or even oppose them, but even say, well, hang on a minute, let's have a think about it. Let's take some time, that they feel you're standing in their way and making them worse. Now, working in psychiatry, your job is not to make people work, but nor is it to go along with everybody's ideas. It's to find a way of empathizing that they feel upset and challenged and whatever, but trying to say, well, but let's try and understand what's going on. That's your position. Yeah. And that, I think, so there's all sorts of things to say. The staff employed are probably the least experienced staff in the trust. For the most contentious area. Yeah. So kids, very fixed, wanting medication, and you're going to have to go, hang on, slow down. Let's have a look at what's going on. That's a tough position to be in. The other thing that's very important was the over close relationship with the pro-trans charities. Let's describe it like that. Yeah. You know, I had a relationship with the adult department with charities, but it's a sort of, they at no stage did they interfere with adult department policy. It's a very strange thing. Whereas in this environment, the trans charities were embedded into the GIDS service. Yeah. In a most unusual way. Yeah.
I think that's the thing that just thinking about a lot of gay men most gay men won't have had any experience of Tavistock or a similar situation like that, but they will be familiar with the charities because they'll have been to events or they know what they are, they'll have heard their messaging. Yeah. So I think that's just a point to reiterate is the what most gay men will understand of what those charities are saying is the charities messaging. They won't have seen, you know, the clinical side of things. So to emphasize how unusual that is, that a charity's kind of lobbying angle really is embedded in a clinical provision, is really unusual.
Really unusual. In fact, there was a leaked document whereby the person in sort of overseeing the service, emails were leaked in which she was sort of wanting the trans charities to sort of more as edit the website. Now, that would never occur in the rest of the trust. I wouldn't. I mean, the British Heart Foundation, I'm sure, you know, in the adult department, you want a good relationship, but there's no way I'm asking the British Heart Foundation to sort of sign off on our approach to sort of 50-year-old
presumably
heart vulnerabilities. I mean,
the other difference there presumably is that the British Heart Foundation would want to be evidence-based.
Absolutely,
it's not an ideological driven purpose.
Yeah, the other thing that the staff was saying was that there's a real clampdown on the freedom of clinical thought. This might be something that, you know, that again, people won't be familiar with. You know, in a clinical environment, you are free to think various different things and look at things from different points of view. That's how you vouchsafe your sort of clinical approach, because there's always downsides to treatments, and there's downsides to certain treatments, there's downsides to not treating. So there's always discussion and a freedom to discuss, and this is very different from a sort of an environment where you're dealing with political ideologies, where there's an idea of there's a right and there's a wrong. See, it's a very different environment. I mean, it's got its place. I'm not saying it hasn't, but it's not in a clinical area.
But again, it's that kind of the thinking about a typical gay man who may not understand or have heard, you know, knows the debate is going on, but hasn't really got into it, or has kind of heard for years the Stonewall or the Mermaids, particularly Stonewall, in the case of gay men, and those sorts of charities kind of official line on stuff, and the kind of simplified messaging around stuff that is increasingly an ideological position, and they won't have taken that as anything other than, well, that's doing good, so that must be right. And actually, in a clinical setting, the whole, you know, challenging what other people are saying to get to the best outcome.
Absolutely essential. You almost need a bit of protection around you, and that was what was missing. You know, it's as if the protection that the service was looking for was from the trans charities, as if, well, as long as they're happy, then we're on the right path. That's why I say that the political tail is wagging the clinical dog. You know, it was like they're our masters, and there's financial implications. You know, the size of the clinical population meant that, you know, there was a lot of money coming from NHS England. This is extremely important, and the influence of the charities is important. So they might say to NHS England, well, we're not happy with the way the Tavistock are conducting this, and it might threaten the contract. Well, you know, the managers would be very anxious about that. But it's a real political interference in a clinical environment.
The other thing that I was thinking of in what you have been describing there, when you mentioned about the conveyor belt, I think this is another thing that, again, if people have heard the kind of the charities kind of lobbying agenda or messaging around there's a really simple, this is what these kids are facing. It's a really simple answer. It's just a pause. It's all, you know, very nice, and it's all very straightforward, and there's no conversation about what else is going on. That's what most gay men in particular who are familiar with these charities, that's the message they'll have heard. So just talk a bit more about that. When you're talking about the medical conveyor belt, both the complexities of the starting point of that, and then what that means for where they're going to go.
So I'll just tell you a bit more about the story, because it might be of interest. So basically, I got interviewed a lot. And a lot of people were very concerned, both sides of the pond. So and eventually we set up a meeting at the House of Lords. And there's several interesting things about this. It was Lord Mooney, who'd been a member of the Labour Party for something like 30 years. You've got to have a sponsor. So he sponsored it. He was threatened by the Labour Party that he would have the whip withdrawn if he sponsored the meeting, and the whip for the Labour Party was withdrawn. The other thing was was that every MP and every Lord was invited. What's that? I don't know, 1,500 people or whatever. Only 2 people turned up, Tammy Gray Thompson, and she was doing an investigation of the effects of drugs in sport. And there was a Tory guy turned up, and he'd been told if he attended the meeting, he could say goodbye to any progression in the party. So you think, what on earth is going on here? Yeah. But we had people from America that, you know, where things are a lot worse than they are here, with, you know, 14-year-old girls having double mastectomies, you know, against their parents' wishes. I mean, anyway, right. So we did a panel. Now, after that, really, the sort of the view was, well, usually you look for medical consensus in terms of treatments, you know, and nice guidelines. Carl Hennigan, who was the professor on the first panorama about this issue, who is basically the senior professor of NICE, basically said there's no evidence for this treatment. This is a sort of live experiment, basically. But nevertheless, you know, there's no sort of consensus and not much interest in finding out what the sort of research is, what the evidence base is. So what do you do when there's a failure of medical authority? And, you know, a lot of our institutions are sort of captured by the ideology and afraid to speak out one thing or another. So then Sue started the judicial review with Mother A. Mother A was the anonymous mother of a 15-year-old girl with autism who was being referred to the GIDS service. And then Kira Bell, so basically Sue, with the lawyer, gathered together experts from around the world who gave evidence to the court. And then Kira Bell stepped in as, anyway, you probably know about Kira Bell. So she became the lead person in the case with Mother A. The thing that the court case revealed was three important things. One was that by the Tavistock's own evidence, if you get on the conveyor belt, you don't get off. People do get off at surgery, but so if you sort of think, and even if you socially transition, you tend to stay on the conveyor belt. Yeah. So the conveyor belt is maybe social transition, puberty blockers, cross-sex hormones. Surgery is different. People don't always go forward to surgery. Yeah. So the idea of pause for thought, that there's no evidence for that. The other thing which is worth mentioning is, I keep going on about evidence, that the judges actually asked, is this all the evidence available? The study and the whole approach is based on what's called the Dutch protocol, a bit of research done on 70 boys, 20 of whom dropped out in 2000 and whatever. Yeah. And the judges sort of asked our national service, where's the rest of the research? There isn't any. Yeah. Which was quite alarming. That was quite a moment. The other thing was, they also asked them what proportion of kids in the GIDS service were on the autistic spectrum. And again, shockingly, they didn't know. Now, in the adult department, adolescent department, you always had to collect differential diagnoses, comorbid problems. That's, again, good clinical practice. So to have a service that was not interested in the sort of overview of who these kids were, quite remarkable. Yeah. Sorry, long answers to your question. I've got a lot to say.
It is I think this is, I'm really keen to have this conversation that's really just setting out the kind of the series of events and the basics, and asking some of the basic stuff, because there will be people who won't have heard this before at all, maybe, or they might have recognized the name because they've heard about the Kira Bell case, but they won't know the detail. They won't know, again, going back to the the messages they may have heard will have come from a very particular political lobbying, ideological point of view. Like it's all temporary, it's all reversible. It's kind of even social transitioning that has a lasting effect. And the further down the conveyor belt you go, the more permanent. It's not reversible pausing or anything like that. It is a very different thing that's being portrayed.
Well, you can't imagine that you could turn off your hormones, which help your brain development, bone marrow development, your secondary sex characteristics. What, you just turn it off and then turn it on like a tap. Yeah. I mean, and I think there are all sorts of concerns about, how the genitalia is smaller. There are worries about bone marrow. There's worried about brain development. Again, we don't know the full extent of it because there's a lack of research. Cross-sex hormones, beyond a certain point, you're infertile, basically. So, I'm not going to say at what stage. I'm not an endocrinologist, but if you keep taking cross-sex hormones, and you've got to take them for the rest of your life if you go down that path and continue down that path, it's not like you take them and then your body takes over. It doesn't, and so I'll just say about Kira Bell, I mean, Kira Bell was really, who everybody knows, I mean, she was the right person to take on the course to court, because, this was someone who had 4 meetings with GIDS and, was then referred on and then subsequently regretted. So she was, someone who's actually affected rather than Sue and myself in the background, who were professionally very unhappy about this situation.
Yeah. So I've been scribbling little bits of notes of the things I'm thinking about in terms of what will most people have heard and what's the reality they may not have heard.
Yes.
You mentioned your kind of work around the area of suicide, and then the kind of statistics around for adult transsexuals and the kind of suicide rates. We've heard a lot around it kind of boils down to do you want a trans daughter or a dead son kind of, and the use or the misuse of the kind of suicide narrative in the kind of lobbying side of things. From your experience, what's both the reality of that you're aware of, and also the difference in that compared to other areas of medicine and mental health in terms of that using the threat of suicide in that way?
Okay, so Sue and I, wrote this book and set up a service, and basically, we get a lot of parents who are really worried. They say, don't mind if my child is trans, but I worry that this is, I've been to the statutory services and there's a sort of affirmation model, and I don't think this has been thought through. And we get several, emails a week basically saying the same thing, that the child is often someone who's sort of on the edge of the group, uncomfortable, may have comorbid problem, but sort of struggles to find their place, and then go along to see someone, because their anxieties increase at puberty, and then they meet the school counsellor, and then before you know where they are, the school say, oh, Joanne now wants to be John, and the parents are terrified. Now then they often get accused by the statutory services of making things worse by not going along with things, rather than being supported as parents who are cautious about what their kids are getting into. Now, one of the things that you find is that they are terrified of this narrative, that they're either going to lose their child, or that they're going to sort of try and harm themselves or commit suicide. The evidence is, Michael Biggs, who has done a lot of research into this area, looking at the various different studies, he says basically, if you take the sort of let's say, troubled adolescent population, and this population, in terms of suicidality, there's no difference. It's not any higher, it's not any lower. The other thing you've got to take into account, there's a lot of internal self-hatred. A lot of these kids are suffering from, they just don't like themselves, and they certainly don't like their body or their natal sexuality. They despise it, and they want it, you know, got rid of or controlled or something. And I think there's a conflation between that self-hatred, and of course it's related to suicide, but it doesn't necessarily mean that everybody who suffers from self-hatred goes on to attempt to take their life. It's a relationship, but it's not a smooth correlation. So again, as you say, it's a sort of, in the vacuum that we would usually fill with our knowledge of the subject, there's all this false science, which is really unhelpful and terrifies people.
And does that kind of, the threat of suicide, not by the individual, but people talking about that as if that's something that would happen, is that something that is seen in other areas of medicine and mental health that you're aware of? Or is that quite different in this?
I mean, you come across that in psychiatric services. You know, it's very difficult to get into psychiatric services. You're in a crisis, and everybody knows that, you know, that, and I'm not saying that this is always the case, cynically, that would be wrong, but sometimes people know that the thing that professionals get anxious about is suicidality. They don't want to be responsible for discharging someone, so that gets used. Sometimes it's rightly used. The problem is sometimes you know, you need to be quite experienced to sort of know the difference. What Sue, who the child psychotherapist, says in terms of the parents just lose confidence in their authority. They feel threatened, you know, for instance, to slow things down or be cautious, or, you know, when the child is saying, well, I'm going to kill myself if, you know, and they've picked this up off the internet. Of course, you'll know as well, there's a lot of tutoring that goes on. They know what to say. I'm not saying, again, you can't comfortably set in a position and say, well, they're all putting it on. That's not the case, but there is a lot of online influence of the sort of messages that people give.
Thinking about the parents, and we said before about individuals who've got other kind of you know, not liking themselves very much, having, you know, that kind of, those sorts of issues. Another kind of, possibly more, so I'm thinking of examples in the States that have been more prominent in the, it's not that you'd rather have a trans daughter than a dead son. It's that I'd rather have a trans daughter than a gay son.
Yes.
And I know obviously the population in GIDS has swung massively to young girls. But we've heard about the levels of kind of either homophobia in the clinic or from parents, and kind of what was your experience of that? I think that'd be an interesting thing for gay men to understand, how many of these are for the boys anyway, and well, lesbians are more so for the girls as well, but how many of these are potentially boys who are going to just grow up to be gay?
Okay, so basically the staff reporting to Dave Bell said that they thought in some of the families that was a real problem. You know, it was a sort of homophobia, you know, as you say, that was sort of driving the families to support the child. And the child also sort of homophobic of their own, you know, sexual desires. Now, and that's something that certainly Sue came across, you know, all those years ago. I have to say, in private practice, and private practice is different because obviously we're dealing with a selected population. It's people who've looked us up on the internet. They know that we're skeptical of current approaches. We're not against transition, you know, not for under 18s, we don't think, but people who have, you know, had a proper psychological evaluation of one thing or another, and transition is going to be their chance of having their best life. You know, of course, we're not there to say no, but But so what I'm saying, the people who come to see us, they're a sort of self-selected group. I have to say, in a way, it's a sort of much more mixed picture. I think, some people hate their natal sexuality. Some people are at odds with their sexual desires. Other people, they just don't like sexuality, full stop. You've got a lot of people who are terrified of sexuality and all that it represents, as part of the transition into adulthood and adult sexual relations. There's a lot of just wanting to shut sexuality down altogether. That's, one of the attractions of the puberty blockers, just don't want to know anything about it. There's often hatred of the sort of, in the girls, I've written a paper about it, that some of them, there's a real anxious attachment to the mothers, but they don't like the whole area of sexuality. And in terms of female sexuality, there's a sort of struggle to own their own sexual body, that they despise their breasts, they despise. The other thing is you get this sort of real stereotyping of the difference between masculinity and femininity, as if you say, well, women are very emotional and sensitive and men are very logical and sort of rational. These kids are often quite sensitive, quite fragile, and they're looking for a sort of transition into something much more solid frame. So we're going to get rid of that femininity, which we really don't like, and we're going to become much more logical. I mean, it sounds very simplistic, but there's a lot of simplistic thinking in this. And sometimes one of the things that you have found with the men, because I see mainly the over 18s and wanting to transition to females, is there's a sense of a real hatred of masculinity. Talk about toxic masculinity is as if anything aggressive, is disowned, pushed into their masculine selves, and they've got a feeling they've got to get rid of it. So if any form of potency, masculinity, sometimes there's a failed father around, and there's a sense that father was to blame, and I want to get rid of all that. So I think it's a the sort of internal homophobia is an important part of the population, but there are other things going on as well. Is my experience.
And that again kind of just reiterates again the thing about it's presented as being really simple and straightforward, and it's one issue when there's actually
100%,
lots going on.
100%. All of these kids, GIDS would say they used to claim, they go, well, the child was very certain. I think, what, certain that they're going to transition? But well, you spend more time thinking about what car you're going to buy. Is it the right one? You knock it about, be a bit confused, have your doubts. So certainty, which is often presented as if it's a sign of health, I think it's a terribly troubling state of mind. It's like, I don't really want any of this questioned. I'm completely fixed. And that is exactly what you're talking about. And actually, they've got all sorts of things going on. All sorts.
I'm interested in I've chatted to a couple of people or talked about this on Twitter and kind of think about this more recently in terms of the idea of certainty for people who have had surgical transition and now are adults and are what we would refer to as trans rights activists in the debate, and they are certain about what what isn't reality, or whether sex is binary. All the messages they say, they're really certain about it, and the lobbying groups are really certain about it. And what I'm particularly interested in from a kind of psychology point of view, I guess, is for those people who have been through a pathway up to and including surgical transition, and for the parents of the children, where the parents have kind of been the responsible adult who has been responsible for that child going through that process, how much of their certainty, or kind of what I'm interested in the psychology of their certainty, having made those decisions that they are lifelong decisions, how much is that certainty reinforcing the decisions they've already made to
Yeah,
themselves?
I mean, the thing is that, you know, with adolescence, I don't know what your adolescence is like, but it's pretty confusing. You know, all sorts of things. Your body's changing, your role in society is changing. You're experimenting with different identities. You may be attracted to, you know, different people and different sexes and different, you know, there's all sorts of things going on. And in a way, it sort of plays its way out. You know, you don't know when the end of the story is going to be and where you're going to settle. And I think that that sort of confusion for certain individuals, they feel it's just too much and they just want to shut it down. And so they almost retreat into certainty as if that's their defensive, it's like a sort of castle or something, going to defend themselves. And you'll see, you know, Kira Bell when in her, you know, it's published, isn't it? A description of what went on with her. She said she was really certain, and this was her, and the doubts were sort of nagging away, you know, somewhere in the back of her mind, not allowing them to come in and influence what was going on. And there's no professional who's going, well, hang on a minute, Kira, let's just have a think about this. And then, of course, you know, tragically for some people who sort of transition and then detransition, is the doubts then sort of come to the fore, sort of after the event, or not for everybody. Some it's before that, but yeah, I mean, in a way. You know, I think you've got to be very wary of fixed beliefs and fixed states of mind. And we know that fanatically held beliefs are troubling. They're troubling for democracy. They're troubling for people's individual psychology. I mean, and particularly when certain aspects of reality are denied. You know, we all struggle with reality. Reality doesn't fit in with our picture of ourselves or the way we'd like the world to be. But we've got to sort of, if we're in a healthy state, we make room for reality and we have to accommodate it. But if we just shut our minds to it, you know, that's not a psychologically healthy state of mind. And eventually may break down. That's the thing.
And then kind of broadening it out, I guess, from the individual to thinking about some of the institutions involved. As we talked about the clinical provision around this issue, but the other kind of institutions, the Royal Colleges, the associations of those sorts of medical and clinical bodies that are, for the most part, going along with the ideological push, varying degrees of, you know, capture, as we describe it, from the kind of lobbying and charities, but kind of what's going on with those in terms of the, you know, why are they going along with it? What's the driver for that? Is it just the, you know, the structure that they are, or particular influences? What's your view on why that part of the puzzle is so going along with it?
So yeah, this wouldn't be a sort of area of strength of mine, but I think that you'd say, you know, in terms of sort of prejudice about homosexuality or racism, you know, certain denial of the significance of sort of bigotry, you know, and now we've come to a position where no one wants to be bigoted. So there's a sort of idea that this is all to do with liberation. You know, paternalism's old-fashioned and we don't want any of that, no one controlling anyone else. So liberty's the name of the game. But the problem is with that is that, in a way, does that mean you have to push out sort of thoughtful reflection and examination of things? You know, not in terms of individuals, not everything that we want for ourselves is necessarily in our best interests. Yeah. And you might think that the sort of institutions are strong enough to be able to examine things and maybe take sometimes an unpopular position at times. But it seems that there's been a capitulation in the confidence of our institutions to say, well, hang on, there are sort of current ideologies, but there's also something in medicine, for instance, called sort of clinical science, and it's not necessarily a comfortable fit between what we'd like to believe currently and actual clinical realities, but somehow it's as if any sort of idea of benign authority, good authority that might sort of stand for something beyond and deal with the accusation of being accused of bias, but say, no, we were standing for medical science. It's like there's a capitulation in that idea in our institutions, and everybody wants to be liked.
Yeah.
Then you end up in a very funny world if the only thing you can do or represent is what people like. That's another sort of tyranny, in my view.
Yeah, I think we've seen. So in reading some stuff ahead of talking to you today, I can't remember now if it's the headline or a comment about the in the coverage when you resigned that you talked about before, about the expectation that this and kind of what was being uncovered would kind of progress the scrutiny about the fast tracking and all that kind of stuff. And we have seen progression over the last few years, and it feels like it's speeding up. Do you get a clear sense that we are moving in the right direction and moving in that direction more quickly?
Well, I mean, I think it's one step forward and 1.5 back, to be quite honest. It seems like there are many more people coming out and speaking out, about this issue. And that's very important, because this whole thing needs to be sort of blown open and discussed and debated. The sort of shutting down of discussion, I think, is one of the most worrying things. It's worrying in terms of our democracy. It's certainly worrying in terms of the effect of the sort of clinical environment. And in schools and what kids are being taught, that needs to be looked at and examined. But every time there's a sort of win, in a way, there are also sort of losses. So, but the key is, I think, that people feel, that this is something worth getting involved in and talking about and challenging, and not just being silenced.
Yeah. Yeah.
And
I was going
to
say that was my kind of question to wrap up with, really, was the I mean, I'm doing these videos particularly from the what is it gay men need to know, but obviously a lot of stuff that people can do is applicable to anyone. But what would you say would be either the best thing people could do or the starting point, particularly for gay men, in terms of the engaging with this or understanding more about this, or kind of what would you encourage people to be doing?
I think, well, sometimes it's a sort of fairly hateful argument, and you worry about the silos in Twitter, and I'm in a particular silo and I see one side of the argument, and the only time you see the other side of the argument was when there's some massive argument between two people. I think that's a sort of rather unhealthy way of carrying on. I think people just educate themselves as to what's going on and read widely. The thing is, we're getting less and less discussion of a sensible sort across what feels a lot of the time like a divide. And yeah, I mean, there is much more out there that is challenging what's going on. And from a clinical point of view, you see, one of the things that is influenced is there's been much more of a shift towards the patient as the customer. So again, we're getting away from the sort of paternalistic doctor saying, right, this is the treatment for you, etc., etc. And that's a good thing. But there are problems with it because, and I know in the health service, for example, you get these patient satisfaction questionnaires. It's basically, did your doctor or clinician, were they nice to you? Well, they should be polite and they should be respectful and not stand on high and look down on the patient. That's absolutely right. But at the end of the day, you really want their best clinical judgment, and that involves sometimes making decisions that the patient may not like. And I think that culturally, we've sort of lost touch with that. The idea that the patient is always right in all circumstances, and you want the doctor just to go along with your own self-diagnosis and self-prescription, I think is extremely unhelpful and worrying. And yeah, so anything that people can do to support the, what shall I say, the establishment of sort of respectful but thinking debate. There's so much non-think around. Just people just believe something because they've been told it, and it seems, a sort of liberal view. But we've got to re-engage our brains, and think about things.
Yeah, I've used that as a reply or starting a conversation with different people when they've said something. It's like, who told you that, and why did you believe them?
Yes,
and kind of go from there.
Yeah.
But yeah,
it was a great thing. Richie Benaud was asked by the cricket commentator. It was asked by a young commentator if he had any advice, and he said, think, engage brain before speaking.
Yeah.
I think that's what we need, a bit of Richie Benaud.
Yeah, I think that's good advice. That's been a really interesting conversation. I hope people watching have found that really useful to kind of set out some of the history of what's happened in recent year and more than recent years. And I will try and link to some of the stuff when I go back through this, and link to some of the things we've mentioned in the description so people can find out more. If you haven't watched any of my other videos and you're watching this one, go and see the other conversations that are hopefully open discussions and getting more, perspectives, point of view. Thank you all for watching. Remember to like and subscribe and to share this. And thank you, Marcus, for talking to us this evening.
Thanks for having me, James. Thanks
Everyone. Bye-bye.